It has started.
Thank you. Right. So yeah, as you're aware, that you should be aware, we usually do this. The meeting is going to be recorded, and the recording will be posted on the division's RAC webpage as soon as it's available. And again, all meeting materials can be found at the Division of Financial Regulations Rules Advisory Committee work group page. And we could put that link in the chat for you. But I did send all the meeting materials out. Was rather late on Friday. I apologize for the late notice, but those were emailed to the RAC members and interested parties that we had on our distribution list. And they're also posted at the division's RAC webpage. So for those of you who may not know me, I'm Lisa Emerson. I'm a health policy analyst with the Division of Financial Regulation in the Department of Consumer and Business Services. Thank you for being here today for the primary care provider assignment rulemaking related to Senate Bill 1529 from the 2022 session implementation. The division is proposing rules for adoption to develop or prescribe a methodology for primary care provider assignment and attribution. Let's see. So yeah, I want to welcome you and thank you for being here today. We're probably going in the essence of time, and we did formal introductions at the first RAC meeting. We're going to forego introductions, but I would ask you to, when RAC members or division staff raise their hand and are called on to speak, just to please introduce yourself and let us know what organization you are with. So that being said, let's go over some virtual meeting etiquette reminders. If you could please keep your microphone muted when you're not speaking, that's helpful. And again, please raise your hand if you'd like to speak, and Karen or I'll call on you in the order of hands that are raised the best that we can. I should be able to keep track, but Karen, once again, I'll ask if you could help me kind of keep track of hands, keep me organized. So RAC members and subject matter expert designees and DFR staff may comment during the main meeting discussion that we're going to have from approximately 1:40 to 2:40, so about an hour. And at 2:40 or 2:55 or earlier, if time allows, there's going to be an opportunity for public comment. So that at that time, interested parties and the public may comment, ask questions at that time. And we do encourage, the division encourages all verbal comments. It's helpful if those are followed up in writing as a written comment, certainly if they're substantive, and if you have, again, any comments or wordsmiths on the proposed rules, that's welcome as well. And also with respect to the statement of need and fiscal impact, which was we talked about in the first RAC meeting, and a copy was provided. So if you have input you can provide all along the way of the RAC process, it's welcome, and a more complete draft will be sent out to the RAC before this whole process is complete. So with that, I think what we're going to do is start with allow some time for right now until we get to going over the draft rules around 2:10 p.m. We'll start with a written comment review, and those documents were sent out to the RAC and interested parties. And I will kind of we'll go in order and start with, in the order of MODA, if depending on who is here today, MODA, Bill Dwyer provided comments, Deborah Rumsey with the Children's Health Alliance, Aaron Balls with Providence, and Antoinette Kawe, I think I got that right, Antoinette, I'm trying, with Cambia will also share her comments. And what I'd like you to do is just hit the highlights and emphasize any of the key points of those comments that you'd like to share with the attendees here today. So Karen, if you could bring up, let's see, is Bill Dwyer here today, MODA, or anyone from MODA?
Yep, I'm here.
Okay, great. So we'll go ahead and put your notes up there, and please, the floor is yours to go over any parts of this that you would like to share and emphasize.
Sure. So in line with my previous comments, we all agree that assigning as many members as possible to primary care is a good thing. The only place where MOTA is not on board with certain elements is this idea that we should try to guess who the PCP would be when we have nothing to base that on. We all agree that connecting members to PCPs is great, but the problem is that in our view, trying to guess does not actually accomplish that goal. And so those 3 points I'm raising here are, number one, I went and compared some of the plans where we have mandatory PCP assignment for everyone versus the ones where we just rely on either a utilization history or a member making an active choice. And in both of those types of plans, the rates of attribution we're able to achieve are very high. In other words, we don't need to try to guess. We're already getting a very high rate of attribution. And the places where we're forced to guess, it just is a large majority of those guesses turn out to be wrong, as we've previously discussed. So you can read some of that at point 2. I'm sort of describing that in detail. And then furthermore, if our objective is to get people connected to PCPs, making a random guess when we have nothing to go on, that does not actually increase PCP utilization. So it's, again, it's well-intentioned, just doesn't work. And so in summary, I just want to point out again that there's no debate about the goal that we're trying to achieve. All we're trying to say is, forcing a plan to guess in the absence of information does not accomplish that goal, and it makes the problem worse by creating erroneous data, which then causes downstream problems with people complaining about who is this, I didn't pick this PCP, or a provider saying this isn't my patient, how come you have this on my list? A majority of those problems are because we're being forced to guess who the PCP is when we have nothing to go on.
Thank you, Bill. Do RAC members or any division staff have any questions for Bill? Any follow-up?
Hi, Lisa.
Yes.
This is Tasha. I do have one question. Sorry, Tasha Sizemore, Life and Health Program Manager for the division. Relative to this question, I hear what you're saying about the confusion. Was this addressed with the legislature? Was this piece of the confusion part of public comment that you provided to the legislature when the bill 1529 passed?
Are you asking me that?
Or just generally, was this a concern that was raised when the legislature enacted the requirement related to attribution?
I personally have no idea.
Okay, thank you. Maybe that's something, Lisa, that you and I can check on. I hear this, but from a compliance manager standpoint, my team is going to be responsible for adhering to the law, and this is a requirement of the regulation. So I'm just trying to better understand, like, have we raised this to the legislature, and are they aware that there's this concern?
So noted. Thank you for that comment. And we can work together to follow up as needed on that. Any other questions, comments on those comments?
Let me just address that point in terms of compliance, and that's
Sure.
the thing I skipped over. I alluded to this in my first paragraph. I believe that an interpretation can be made. I've read the text of the legislation, and I certainly think that it would be a reasonable interpretation to say that what was intended here and what should be best practice is to attribute all members where possible.
Thank you. All right, let's go on to Deborah Rumsey, the Children Health Alliance.
Hi there. Again, Deborah Rumsey with the Children's Health Alliance. Sorry, this is a little bit lengthy, but really my intent of writing some written comments was to help provide just some additional background or thoughts and considerations that might help in shaping the points or adding some narrative around how it could be implemented and or why this might be important. So I went through each of the different points. Some of which is not of concern. Everybody agrees with patient's choice and the importance of that. Also talking about on the attribution, just some of the considerations when using claims-based attribution when patient choice has not been made, that's in B. And just as it's looking to be implemented, to attribute based upon claims history, just to be aware that there are some types of utilization that could lead to incorrect attribution, such as urgent care locations or utilization of services that are one-time, single instances of a service. We experienced quite a bit of inaccurate attribution or moving of patients that were ours as a result of COVID clinics, for example, that were outside of the patient, not associated with the medical home, but elsewhere because of the mass vaccinations. And so patients were inappropriately moved. So again, just considerations of implementation, but perhaps not necessarily related to the specific language of the rulemaking process. In addition, I think our caveat or suggestion on C, which was when there's a predominant utilization with another PCP, and I saw this in your draft rules, that really it should be, again, go back to patient choice. And so if that is noticed or identified, that it should be confirmed with a patient before a change is made. I think that that's a fair way to do that and allows for that outreach with the patient and confirmation of their process. And there should be also multiple ways that one might be able to confirm that, whether it's an easy mechanism for the patient to be able to notify the plan that they've changed their PCP selection, outreach by the health plan to confirm the desired provider, or a mechanism for the selected PCP to notify the health plan when they contact the patient and confirm that the patient choice has changed through some attestation. So there could be multiple ways to ease that change in PCP assignment. I recognize the challenges that Bill says in D, and again, the intent is to assign as many as possible. And so I don't have a specific suggestion here other than the importance that as many patients as possible are assigned a PCP to help support the intent with total cost of care, with value-based contracts, and really the intent and access to care for those patients. So we really want to encourage outreach and engagement of all patients for the best health for that patient. And lastly, just again, the importance of the mechanism to correct or change that patient provider assignment and why that is important. And it goes back to those same mechanisms that we had discussed before. So it wasn't necessarily nitpicking on the language, except for when confirming patient choice if a change is made based upon utilization, but really trying to help understand what some of the areas of importance would be in attribution and some considerations as either the state or the health plans are implementing some of those processes. So I'm happy to answer any questions, but it was really supplemental information.
Thank you. Thank you for summarizing that really well. Bill, if you would go ahead and ask the question.
Sure, and I just wanted to comment on the, and I agree with everything Deborah's saying there, and there's one place where she was mentioning about a discrepancy between utilization and the member choice. And just to give you some examples, I also went and looked at that. And there's just thousands of examples in our data where, you know, just to pick one that was notable. We had a member that visited the same PCP 33 times in a row, you know, having, you know, dozens of visits over a 2-year period. This PCP is not the PCP that they're assigned to. And we can't get a hold of this person. We cannot, you know, sure, we send them letters and, you know, but they're not being responsive to change their PCP. And so I just think that this is an example where, you know, a health plan acting responsibly should have the freedom to make this edit when it's obvious that the data is not accurate without hamstringing us by additional requirements to contact a member or to reach a member. So allowing some flexibility for us to conduct our operations in a way that is practical and has common sense is, I think, the way that the rules should be written.
Thank you. And I'm hoping that when we get to the rules, that's what we were attempting to do, was build in some flexibility. So we'll definitely get to that here in not too long. Any other questions, comments for Deborah? Okay, let's move on to Providence. Aaron Balls.
Good afternoon, everybody. Aaron Balls with Providence. So yeah, our comment letter touched on a lot of the same issues as everybody else, perhaps not surprisingly. Started with a discussion about the scope and definition of primary care physician and how that works in the attribution context. One thing we pointed out is that we would like the rules to permit attribution at either the individual clinician or a clinical level. In practice, that's how it works for many providers and payers today. There are some clinics that have a model where it's less one-to-one provider, and it can have benefits for consumers to be assigned to a clinic versus an individual physician. And we're hoping to see potentially a change to some of the language in the draft rules to make that a little clearer. Another item that we talked about was just, what can be who is a PCP as defined in the statute. We think that sticking with the statutory definition, to the greatest extent possible, while still recognizing objectives like the clinic level assignment makes sense, rather than say put out a list of all right, only these provider types can be PCPs. If the individual provider type fits in this type of definition, that should be permitted as a possible position to be assigned to. Then attribution methodology, once again focusing on the provision that folks have been talking about here today, where you see in utilization data that a person is seeing a provider other than their assigned PCP, not having it be, I think the original sort of work group language was a mandatory reassignment to the utilizing or the PCP that's being utilized. And we were recommending more respect for patient choice there. So, we are seeing that in the rules. I do think we'll hopefully talk a little bit more about that specific language, because I don't know that mandatory reach out is the right way to go. And the language could be read as being requiring that in all cases. And then, let's see. Yeah, I think being flexible around assignment methodology for those tough cases like have been talked about here, where we lack information around utilization to make a good choice. So that, I think, is our summary of our comments.
Thank you, Aaron.
Thank you.
Any comments or questions for Aaron for the Providence's comments? Okay, we can get more into it when we get into the draft rules review. Let's give Antoinette Cambia an opportunity. She's here today.
Antoinette is actually on PTO, so I am filling in for her if that is okay.
That is great. Thank you, Marianne.
She's out for the next few weeks. So hi, everyone. I am Marianne Cooper. I am the Director of Government Affairs for Oregon. And yeah, I'm happy to summarize. I will say we gave, I think, a lot of feedback on the value-based payment model that we don't necessarily need to drill down too deeply into. I will say we still have concerns, and even as it is drafted in the rules that we saw around HIPAA compliance and how we can comply with HIPAA when we are communicating out attribution to providers that patients may not have a relationship with. So I think that's an outstanding question that needs to be addressed. And then go ahead and scroll down. And again, I think some of this was in the weeds of the value-based payment model. I think I'll skip down to the attribution. I think we have the same concern that a lot of others raised around overriding patient choice as it relates to the PCP they chose if they have predominant utilization with someone else, and had recommended either reaching out to the patient to confirm they want to stay with the PCP, but something that doesn't force the plan to assign them to a different PCP based on utilization and override that choice. And then have some outstanding questions about kind of the method of assignment when we get into assigning. And again, a lot of this is down in the weeds of the value-based payment model, so I'm not sure if we need to address it too deeply. So yeah, I think, again, I'm not sure any of this is relevant to the rules as I've seen them drafted, so don't need to drill down too deeply, but happy to take any questions.
I see Jennifer's hand is up. Please go ahead.
Hi, Jen Baker with Cigna. Marianne, thanks for your comments. I just had a quick question about the HIPAA issue. Is Cambia in their respective review of this, are you saying that you believe this would be a HIPAA violation and therefore be preempted by HIPAA? Is this a preemption issue? Because if we are not permitted to share that information with a non-established relationship provider for the member, I'm wondering if then we're not allowed to do that then.
Yeah, how it resolves. I think we're hoping it gets resolved in rulemaking to avoid a HIPAA violation, because I think otherwise we would be left making challenging choices. And again, it might be an us issue, but our current attribution process does involve sharing PHI. And so we do need to see that addressed.
Yeah, I'm curious how the DFR would respond to a preemption issue by forcing carriers to choose when there's not enough data available.
That's a good question, and we'll need to discuss that further after we look at the rules. I have a question for the other insurers. How are you handling it right now? For those, yeah.
I would say, since we raised it, I'll answer. I mean, I think we are not providing any PHI if there's not proof of an existing relationship that allows that disclosure, is my understanding. But Bill is before I go
to Bill and Jennifer, before I go to you, I just a follow up for Marianne. So you can still pursue communication between the provider and the potential enrollee without violating HIPAA to a degree.
I don't know. I would need to talk to our legal on the answer of that question of where the nuances are of what we can share. I just know that right now our current process, there is PHI that we share as part of our attribution process, and we don't share that without evidence of an existing relationship. And hopefully Bill has an answer that's better than mine.
Okay. Are you done, Jennifer? And can we go to Bill? Okay.
Go to Bill.
Yeah, I was just going to agree that, yes, when we assign a member to a provider, we send that provider a lot of information, a bunch of PII and a bunch of PHI on that member. And, it's a bit of a flimsy justification for that under HIPAA if we're just having to guess who there might PCP, when there's no existing relationship. So I agree with those comments that it's a concern.
Noted. Thank you. Okay. Let's see. Any other questions or comments before we move on to rule review? Michael? I see your
Hi,
hands up.
this is Michael Schaff at the division. I just want to clarify on the HIPAA concern. The concern is, so as a health plan, you assign member X to provider Y. And as part of that, you send some communication to provider Y, giving them information about member X. That's where the HIPAA concern is. I just want to make sure I'm framing that correctly. Can someone confirm?
Yes, that's right.
Correct.
Thank you.
Well, I think that the rules require us to send information to the provider.
The draft rules at this moment, yes.
Yes.
So we'll need to maybe work through some of the nuances of that. Deborah, let's go to you.
I don't have the answers, but my question is, if it is a patient where there's not an established relationship, does sending information, contact information for patient outreach fall under the allowed reasons that you could exchange patient information for operations, payment, and treatment? And so if that's what the intent is. Now, when you get to the detailed health records, where a plan might send additional information to support other elements of a program, that might change. But I would think that you should, when it's being looked at by the people, by the appropriate folks, that they look at the allowed reasons to send PHI to between providers and payers. And so we should consider, does it fall within one of those? And if it does fall within either payment or a quality measure or otherwise, it could fall under one of those allowed reasons. So I think the devil's in the detail, and it should be looked at along with that evaluation. And I can't tell you what the answer is because I'm not the expert.
Let's see, a follow-up question from Marianne, I believe.
Yeah, and I'll stop here, but I just wanted to put a bit of a finer point on it. And I don't have the answer either. I think the biggest concern is where the patient has had no desire to seek care, right? They have no evidence of having sought any care. So for folks that have an existing relationship, I don't think we have concerns, or there's no evidence of them wanting to seek care, and we're supposed to assign them and communicate information to a provider for them. You have no affirmative action on the part of the patient that shows that they had any desire for this person to receive, this provider to receive any information about them. And I think that's where the biggest concern comes in. So I just wanted to kind of put that fine point on it. We're not talking about folks with a utilization history and kind of an existing relationship, but rather folks with no relationship that have evidenced no intent to want to share that information.
Understood. Thank you. All right, let's we have another hand. Aaron?
Hey, I'm sorry. Don't mean to be a pest. I think that my understanding on how HIPAA works is treatment, payment, and healthcare operations generally requires a shared relationship to fall underneath that exception. So that's the challenge that our friends on the call are explaining, and it's a real thing. There's tension between these two laws, and I think reading out the requirement to assign is certainly one way to deal with that for those that don't have utilization on record. But it's, I guess, up to DFR and the DOJ to decide if that's possible.
Thank you, Aaron. Tasha, you have your hand up. You want to follow up?
Yeah, just a similar question on the HIPAA piece. To the question I asked earlier, was this something that insurance stakeholders raised during the legislative portion or the legislative discussion of 1529? Just once again, trying to get the scope of these compliance issues and what we might face in terms of compliance.
Yeah, I don't recall specifically. I do recall some of the lobbying around this bill and it being focused primarily on the like 3 free visit type work because there's multiple provisions of this particular bill. So I would be surprised if there's anything in the legislative history about HIPAA or privacy barriers.
Tasha, this is Scott from MODA, and it may be just that we, in the bill, there's provisions about future rulemaking around attribution and PCP assignment. So, I mean, it's logical to think that we thought it would be addressed at that time like we're doing right now. I wasn't there in this role at that time, so I can't speak to what MODA had said or not, but that seems logical to me based on how the bill is written.
Fair enough.
Thank you. Let's go to, I saw the hand, but I think it's Jennifer Baker.
Yeah, can I just follow up on that really quick? Just to kind of back up what Aaron was saying, there was most of the discussion was focused on the 3 visits and the potential conflict that it was going to have with certain plans with the no cost sharing piece. But I guess I would like to, throw the question back to the DFR. Was there any legal analysis done by the state in terms of potential federal conflicts with this proposal? Because, I mean, it goes both ways, right? I mean, did anybody do a quick search to see if there was going to be conflicts with sharing public health information to doctors that have no association with our members?
Yeah, great question, Jen. And from my experience on the policy team, and Lisa and Michael and others who currently are policy advisors can share, we do blue sheets and do work that and policy analysis that does raise these questions. And I have myself in the past raised HIPAA questions. The reason why I'm asking specifically what was, I guess, lobbied on, to use the term that Bill and Aaron and others have used from industry, is because agencies cannot come out in support or opposition of a bill unless directed by the governor. And so one of the things that we're up against is if this is something that the legislature felt really strongly about and implemented this, like, we can't do the same level of lobbying that outside organizations can do. So when it comes to the next step, which is what we're doing now with rulemaking and then compliance and stuff later on, we on my team and just kind of the division generally are tasked with, okay, I guess, sending objections and sending questions to insurers. And if this was an issue raised by insurers and something that was effectively lobbied on, then and addressed or in some way by people on the committee that originally heard this bill, then that may be something that may produce a different result in terms of how we handle compliance questions going forward. So that's a great question, Jen. It's just oftentimes you guys
Tasha,
can do stuff that we can't.
I understand that, but I'm just looking at Section 8 of Senate Bill 1529 again, and I really don't see anything in here that says insurers are required to guess a PCP for a member they have no data on. And it also does indicate that the rules must prioritize consumer choice. So, I mean, I think that the language here does give us this flexibility to not require insurers to make this, giant leap on behalf of our members. So I'm really hoping that the DFR is going to pursue that, because I don't think there's anything in here that I guess what I'm trying to say is there's no way we could have known, back in 2022, you guys were going to say, okay, and by the way, you're going to have to send all this PHI to doctors that members have no idea who they are. I mean, how could we have foreseen that was going to be in the rules?
Thanks for your comment, Jen. I don't think that was the intent, and I don't think that the administrative weeds aspects were all figured out. This is what this is why we're having this process right now.
Exactly.
And I don't think our rules would ever want there to be a rule that would create a HIPAA violation. So it's a matter of having insurers' administrative processes work with the intent of the bill. But the bill does say assign a PCP. So that's one we kind of work with, and we can go back and take all these comments back and take a closer look and see what can be done to make sure that insurers aren't put in that position of potential HIPAA violation. So
bingo, Lisa. And it really helps to know that, you know, this was not something that you anticipated, and that industry may have been waiting for these conversations to come up to have that is something that we can work with at the division when we get questions from legislators. So like I was explaining, we do a lot of this work and we do point this stuff out. It's just we are limited as a state agency in how we can provide feedback in these situations.
And Tasha, I will just add, my understanding is that because it was a short session, that there was very little conversation. There's a lot of kind of behind closed doors conversations, but very little kind of on the record and formal conversations, because it, you know, it was in a different bill and they got admitted to this bill and multiple pieces came together. So I think it was pretty rushed through the legislative process. So to me, it's not surprising that there's a lot of outstanding questions about implementation of the bill in its entirety, because I think it was an idea that maybe didn't get as vetted as it would have in a longer session.
And that's consistent with some of the conversations, the follow-up conversations we've had with former Rep. Prusak and on this matter. So these were some of the more finer, weedy details of implementation that we will continue to work through.
And Lisa, this is Scott from ODA. I just wanted to help out with the privacy discussion. It's 45 CFR 164.506, talks about covered entity to covered entity PHI transmissions. And it does state that each entity either has or had a relationship with the individual who is the subject of the PHI. Just wanted to provide the reference.
Thank you. I appreciate that. Okay, let's maybe go ahead and we'll bring up the draft rules and go through each section and gather feedback and comments. I can say already up front that, as I mentioned before, we'll definitely want anything that's verbalized here today. It would be very helpful. It could be followed up in written comment. If it's wordsmithing or other recommendations, we're very open to receiving those. So let's have a robust conversation here, but I won't be, taking copious notes. We'll have the recording, but really would appreciate written comments on anything of substance with respect to these draft rules. So yeah, I'll kind of just have you scroll as I read through my notes here. And I'm kind of giving you the background of our approach to drafting rules. So the discussion draft administrative rule, we've numbered 836-053-028, and it was placed intentionally directly following another a temporary rule related to the implementation of Senate Bill 1529 with respect to the co-payments for certain primary care visits. It seemed like a logical placement within OIR Chapter 836, Division 53 rules for health benefit plans. So that's the logic there. And as I talk through this, just you catch me, Karen, if you have if you see any hands raised or any important chats that we need to visit, because I can't look at both. Okay. And so 1A, we've started with defining enrollee, which is a definition that's already in this chapter of rules. DFR refers to enrollee versus patient because the DCBS DFR regulates insurance plans. And so insurance plans are members, but enrollee is the term. So we followed what is used in temporary rule 836-053-027 I use the same definition that's used there in this draft rule. That's the rationale there. And then for 1B, we thought it's important to include the precise language that's in Senate Bill 1529, Section 8 for the definition of a primary care provider. As some of the written comments have recommended, it's clear that a clear definition that we are not wanting to get more deeply prescriptive about, that it should be a non-specialty medical services and a primary care provider that's licensed in the state to do outpatient non-specialty services or coordinate the healthcare. So there's a lot of providers that aren't coordinating healthcare. I would say case in point, an urgent care visit wouldn't necessarily be like what you would think logically as a PCP assignment. So that's just an example there. So we didn't want to go deeper on this and just leave it to how insurers approach this. And, you know, there's some more information forthcoming from Tasha in terms of compliance, the things that they would be referencing. And I think it was referred to in written comments from Aaron with Providence about looking to some cohesion or coordination with the cost growth target program and all the guidance that's in their instruction manual, guidance for payers reporting for that program. And they have indication of what is a primary care provider service. So that has some consistency there, which also is consistent with the work of the primary care payment reform and the value-based payment work group and that work there. Everyone's kind of trying to coordinate and look to each other for a logical approach to this. So that's for 1B. Any questions there? Comments? Let's start with Deborah.
Thanks. I actually think Aaron might probably have the comment that I'm about to say too, but I respect and appreciate his comments with primary care provider or the provider clinic, because that assignment might happen at the individual level or the clinic level. And I don't know if there's a reference to the patient center medical home that would be appropriate language or how that might be, but I agree that that's also an equally acceptable method of assignment. And so it was his point, I believe, that I'll let him talk through.
Yeah, no, you covered it well. Thank you. I think there's different ways you could get at this from a language standpoint. You could say an individual or organization licensed or certified in the state, say an individual or group of individuals, but something acknowledging that, it's permissible to assign at the clinic level, because that's just how many clinics are structured. And how many value-based care arrangements are structured.
And thank you for saying that, both of you. I mean, that was acknowledged in our review. It just, we were having a hard way seeing clear through the statute, the law that was allowed. And so this is good, further discussion on this. And I want to hear from everybody's comments, and we'll take that back and see if we can find a way clear to do something like that. Because I realize that factors into the reality of value-based payment arrangements. So
from like a statutory flexibility standpoint, I think, clinics are also licensed. Groups, individuals can form together, and those individuals can be licensed. So just practically, I think there's ways to read through that.
Thank you. Let's go to Marty with the primary care, Oregon Primary Care Association, and then to Marianne. Those are the two hands I believe that are out. Marianne's was first. I'm sorry. Go ahead.
Yeah, so we've raised this, and I'm not sure if this is the place to raise it, but I know that DFR had previously declined to answer this because of the ongoing rulemaking. So I want to go ahead and raise it here. I think we had outstanding questions about kind of, is this inclusive of urgent care facilities? Also kind of in versus out of network. Are we kind of good to only assign to in network? And then just wanted to know kind of the full scope of again, I think others raised this, like somebody that's seeing an OBGYN or, you know, some of the specialty providers that we've said count as primary care. So I think, again, if this definition's in here, I just wanted to raise those questions. I don't know if it needs to be handled in the definition or elsewhere, but it seemed to be indicated that it would be part of the scope of the rulemaking. So I wanted to throw it out there.
I'll give the floor to Tasha. We've had an internal work group that's worked on this, and there's more information forthcoming. But Tasha, if you'd like to say some comments about that.
Yeah, so generally, let's start with the in versus out of network piece. Generally, in review of the law, we believe that as long as an insurer has an adequate network of in-network providers who meet the definitions of the statute, that there would be no reason for an insurer to need or be required to assign to an out-of-network provider. The big piece there is whether or not an insurer has an adequate network of in-network providers who meet the requirements of this. And I know of the law, and I know that that was some of the comments that occurred last week during the meeting, was some concern that if there were, or last week, a month ago, if there were concern that there may not be enough providers to do the amount of attribution that would be required under the statute. And so knowing that that is continuing to be a conversation, that is why I deferred more conversation around that particular piece until we could have more discussion about the attribution component of this. So that's the in-network versus out-of-network. I think Lisa earlier made the comment about, you know, urgent care would not fit within this just because of the type. However, Oregon, the one type of provider that, or I guess two, there are two types of specialty providers that kind of fall within that other classification that you mentioned, Marianne, and those are OBs and pediatricians, that our law says that those have to be able to be assigned primary care as primary care providers, or that somebody has the ability to choose those. I guess, and that's in 743B. I can get a more concrete statute here in just a second. But that's in 743B.
I can find it.
Thank you, Lisa. So I think that, you know, generally anybody who could be assigned a PCP because of their licensure, and then once again, OBs and pediatrics, because they are statutorily required to be allowed to be PCPs.
And Tasha, can I ask a follow-up again, just because we were directed to this rulemaking for that? So if we're talking about the use in terms of the 3 free primary care, do those answers still hold? So it can be just in network and non-urgent care?
Yes.
Okay.
So I think that the way that the 1529 is worded is that it is really primary care, and that would most commonly not happen in an urgent care setting. But using pediatrics as an example, my kiddo has to go to a pediatrician. My kiddo goes to a pediatrician several times a year, doesn't have to, only has to go for her well-child checkup. And so the outside of the well-child checkup, which would have to be no cost to the member, there would be 3 visits that if that pediatrician was providing primary care services, like, you know, waiting for an appointment because of an illness or something like that, that would be captured under the statute 1529.
Okay, thank you.
It's 743B, 220, and 222. And I'll put those in the chat.
Thank you so much, Lisa.
Let's go to Marty. I see your hand is raised. But maybe you can't hear me.
Are you saying me?
Yes.
Oh, I'm Tony German. I'm with Ord Academy Family Practitioners.
Okay.
That's okay. Sorry about that.
Pardon. Too many
be-
screens. Too many things on my screen.
No, that's okay.
Go ahead.
He's a good-looking fella. Not to be redundant, but just I think that the comment with reference to Mr. Balls and Ms. Rumsey, just want to add support to layer the understanding of, a medical home and understand the structure of healthcare, and with the difficulties with which we have in turnover in primary care, and understanding that does shift in care, particularly myself working in a federally qualified health center, that reassignment happens within a clinic or health system. And that the ongoing care from a value-based perspective continues within that entity. So we support that approach and appreciate that wording offered with 1B.
Thank you. Okay. Any other questions or comments so far? So let's go to, let's see, to 2. With respect to 2 and 3, the language was taken directly from the bill in Section 8 to provide a clear background for the purpose for adopting rules, for DCBS adopting rules, prescribing a methodology for PCP assignment and attribution. So we just kind of felt that that would provide clarity for the next pieces in the rule, like logically. So that's why that's in there. Any questions, comments about that? And then for 3, this language seemed very important to emphasize, considering that enrollee or patient choice is to be prioritized, and that they may change a PCP at any time. So we put that in there for emphasis in the rule. And then 4A through D and 5 is language that's consistent with recommendations from the Primary Care Payment Reform Collaborative, VBP model work groups, core recommendations that we reviewed in the last RAC. And we made some adjustments, based on feedback from the RAC and interested parties. But we've also talked more granularly about some of those issues that we still need to work out within these this hierarchical order that PCPs should be assigned. And so, we've had the issue of, HIPAA. So if there's no utilization, there could be a HIPAA violation by sharing PII, PHI with a provider where there's no relationship. Also we've got the topic of another key point we want to look to some more about assigning a PCP at the clinic level. We need to talk through that internally some more. But let's, look at, starting with 4A and see if we can get some feedback from you on, any immediate language that you have concerns with. So 4, insurer must assign and attribute enrollees to primary care providers in this hierarchical order, starting with A. Obviously, it's the patient choice selection, and insurers communicating with enrollees and in all manner necessary to prioritize the enrollment with the provider of their choice. I was trying to get at, I think Deborah had recommended, or there was language in the VBP work group's recommendation to have that be in the enrollment information right off the get-go. And we didn't quite have it in there like that, but I hope it gets to the same point here. So let's start with that. And Marianne, you have your hand up. Go ahead.
And this might be something I missed in the VBP methodology, but what does in all manner necessary mean to the division?
Good question. I think we could be more specific. If it's letter, phone, email, we could be more specific, but it's to kind of show that all effort's been made to reach your member, your enrollee, to communicate that you need to choose a PCP by the 90th day. Hopefully you're getting that right up front. Now somehow incorporating that into the enrollment process more proactively, that they choose a PCP and not just the plans that require it from the beginning, when the enrollment materials. So we can refine that language, but that's what we're getting at. with it, but it's probably
Okay.
not specific enough.
Yeah, that whole middle, just in all manner necessary to prioritize enrollee choice, like it
Yeah.
just, I think the thing you're wanting us to do is to complete the initial primary care provider assignment or attribution. And so I
Yeah.
feel like the middle, the meaning is a little jumbled to me when the desire is for us to communicate with enrollees to get them to complete that assignment or attribution, that, you know, their choice. I just feel like there's maybe a plainer way of saying what we mean there.
Okay, thank you. I can't see the name of the person with the hand up, but please go ahead.
Hi, it's Amy Grant with United Healthcare. A couple of things. So understand that the language being looked at again for that assignment process when we have no attribution ability, so we're kind of flying blind. But back to the respect of having a clinic versus an individual, we have providers who are literally contracted as PCPs at that clinic level specifically for that purpose. So there, and I don't know if other payers do as well, maybe see some heads are shaking, but we have contracts that actually support that. So I would hope that wouldn't be overwritten in this rule, because that's how some group contracts work today in terms of assignment at a group level.
Okay, thank you for emphasizing that. I'm gathering that now as we're talking more about these things. So thank you.
Thanks.
Any other question or comment on 4A? Okay, so moving to the next step, next level of decision making, 4B. So if the enrollee doesn't choose a primary care provider, insurers will assign or attribute the enrollee to a provider based upon claim utilization information using the insurer's attribution methodology. So the intent here, again, was to provide flexibility, insurer to insurer, and not be too prescriptive in this area of attribution, which involves contracting VBP arrangements that the division doesn't have the agency doesn't have regulatory authority over. So that's that building in that flexibility. That was the intent here. But prioritizing that utilization information should be used if it's available. And you're welcome to make comments now, or we welcome, again, follow-up comments in written form. Michael.
Hi, Lisa. Excuse me. This is Michael Schaff at the division again. Just want to flag both for you and for folks that the use of assign or attribute in B is a little confusing to me. I think it might be helpful to just talk about, is there a distinction between those two things or not? I know the bill talks about, all the members should be assigned, but then in the rulemaking sections, it talks about assignment and attribution. I'm not, I just want to flag that might be something we want to be clear on, is what are those different things, and when does one end and the other begin, or are they part and parcel of the same thing? Sorry to cue that up, but I thought it should be brought up with the group.
Yeah, I've been, obviously reading a lot and getting a lot of different resource information from the Primary Care Payment Reform Collaborative, all the RAC members who've shared their information. And I believe they are two different things, whether or not that needs to be defined in rule. Attribution has to do with, I believe there's a value-based payment arrangement or a compensation arrangement that's tied to the assignment of the patient. And it's, whereas assignment is just, I on the face of it, I see them as two different things. Or why were the two words used in the statute? Anybody from the insurer community want to comment on that, or from the Primary Care Payment Collaborative VBP work group? Okay, Bill, please.
Yeah, I'm in the Payment Reform Collaborative Work Group, and I would just tell you that I don't think that there is a consistently understood difference between those two. This has come up in our discussions. You probably ask 10 different people, and they're going to give you 10 different answers. I personally would not think that the difference between attribution or assignment would have anything to do with a VBP model. The way we use that term in MOTA is assignment just means that the plan chooses whereas attribution means that you have something to go off of, such as a utilization history.
Thank you for clarifying. I think we need, I mean, the approach is that that's what's in the statute. So would there be any, what would be the objection if we took one of those words out? Or or is there a preference to use one word versus another word term?
Can I just follow up with a additional question there? Would it
Yes.
be confusing if we got rid of attribution and that was continued to still be used by your organization, or assignment? Like, would it cause confusion if we were to basically focus on one word for our rules?
I don't think so. Yeah, it'd be fine. Yeah, it's still clear that you're assigning it based on claim utilization. I think attribution is generally the word that we use to talk about doing that. So you've got a member that didn't choose and you need to attribute them to a provider. But I don't think for the purpose of these rules, it really matters if you were to just go with the word assign based on claim utilization. Might eliminate some confusion.
Okay, thank you. Thank you for bringing that question up, Michael, and for everyone's comments. We appreciate that. All right, then looking at, let's see, through 4C. We've kind of already talked a little bit in advance about some of this, but if the enrollee chooses a primary care provider that has predominant claim utilization with a different primary care provider, the insurer will communicate with the enrollee the opportunity to select the primary care provider with the predominant utilization. Again, that's just checking with the enrollee a priority. Don't just do it automatically. So we were hoping that would address some of your concerns. Let's see. I think it's Mary Ann first, and then we'll go to Aaron.
Yeah, and I think when I first read this, I was like, oh, great. That means we can respect their choice, right? And enroll in the person they select if they, don't take us up on our offer. But I realized it doesn't actually expressly say that. And I would prefer that it does say like what happened. So they choose a provider, they have predominant utilization with someone else, we communicate. Do we still get to assign them to the one they chose? I assume yes, but I just wanted to clarify that was the intent.
That was the intent.
Okay.
But if it's not clear enough, we can wordsmith to make it clear. Yeah.
Yeah, I just feel like in B we say insurers will assign this way, but in actually A and C, now that I'm looking at it, we don't expressly say how we will assign. But I presume that
it says insure. In B it says the insurer's attribution methodology. So we're not going down into
no.
kind of
Sorry, I'm
internal
just saying that like it doesn't actually say how we will assign in C, and
okay.
It maybe doesn't. I can't remember what the language in A says before that, but again, for it to be clear, I feel like it should just say this is how you assign. Okay.
Yeah, if you want to take
yeah,
offer some language recommendations, that'd be great.
Yep, happy to.
Aaron, you're next.
Yeah, thank you. So the language, it says the insurer will communicate with the enrollee the opportunity. I would suggest that be changed to something more permissive, like the insurer may, because if this section is not in the statute, so we're not bound by that specifically. And I view this as like a tool in the toolbox to try to like course correct if a member chooses one PCP and then goes and sees another. The word will creates a compliance obligation that doesn't exist today for the insurer to do that. So that leaves us to interpret like, okay, at what point does it become predominant claim utilization? We have to communicate with the member, and it may not, leaving that as permissive makes it a tool in the toolbox without creating like a pretty complicated mandatory outreach to members if they veer away from the PCP they actually chose.
Okay, thank you. Yeah, this was all, done in an effort to be consistent, like the language in the bill be consistent with the primary care payment reform collaborative recommendations. So I will make a note of that, and we will see what we can do in that space.
The collaborative isn't a statute, I guess is what I would say. So I know we have to abide by that statute, but I think we've got more flexibility to decide as a group here what makes sense with respect to this tool in our toolbox.
Thank you. Yeah, I think consistent gives room, for some of that flexibility that we're talking about. So for what has to be done in the real world with assigning patients or enrollees. Okay, and then if you want to scroll forward, let me look at the chat really quick. I don't know if we have something new in there. Okay. Thank you for the chats. We'll definitely go back to these. And so with D, the insurer has no information pertinent to choice or utilization. The insurer will assign the enrollee to a primary care provider. And we were trying, again, to be flexible here according to any reasonable methodology that enables an enrollee to best opportunity to access covered primary care services without unreasonable delay. And that is something we commonly use in rule to, emphasize the purpose for this rule, but it can build in flexibility. So whether you have comments now or you want to follow those up with written comment, that's helpful. But we also, I've taken note of your concern that's been raised about just assigning some of those hard to assign folks because of the HIPAA and the other issues. So we'll need to come look at this one a little more closely again. Hand raised is.
It's Jen Baker with Cigna.
Okay, thank you.
And my only suggestion here for now would be to add some sort of language, that says the best opportunity to access covered primary care services without unreasonable delay, or something that, or does not conflict with federal law. I mean, because I think we want to, I guess keeping it broad is my gut instinct is, we have no idea what other potential hurdles we might encounter in this process. And so, that would be my recommendation.
Thank you, Jen. Okay, I've got other hands. Let's go to Scott White and then to Bill Dwyer. Or now it's just Bill.
Oh, sorry. Yeah, this is Scott from MODA.
Okay.
So, and even just adding does not conflict with federal law. As Tasha mentioned, kind of the way the rule is written or the DFR is looking at it, that it does require this. I'm going to use the word assignment because we're just going to go with that one for right now. And so if we say, we can do this or it does not conflict with federal law, but there needs to be something else that would kind of clearly state that if that was the reason during some sort of audit, and I don't know how to state this, but we could say, well, that conflicted with HIPAA and therefore we did not do that. But I don't want to come back in a market conduct audit and have, this come up. So just something to protect against that. And then that'll depend on what we find or what the DFR finds for this scenario anyway. But I just wanted to throw that out there as well as an additional concern.
All right. Thank you, Scott. And then let's go to Bill.
Yeah, my suggestion here would be to, what we ought to say here is, if the insurer has no information, no patient choice or prior utilization, then the insurer will assign the enrollee as soon as such information becomes available. That way it still meets the spirit of what the law is trying to accomplish, while giving us the flexibility to not do these assignments, which cause a host of downstream problems. And I can put that suggestion in the chat.
I just want to like bag Bill up. That's a really
like
good.
that too.
That trumps mine. So.
Okay, thank you. Appreciate it. And then I see Tasha put some information in the chat as well. Okay, Tony, your hand is up. Let's go ahead.
Yeah, I appreciate all the concerns with, the challenges are certainly here and the intentions. I just am curious, what does that mean, and what is that outlined as far as the intention of carriers to pursue that information, and what does that look like would be a question I would have. I know that probably that would be made an initial intake, but does it end right there, or is there a follow-up piece? I mean, that's the concern I would have with that. I did have a question regarding, attribution and insight that maybe OHA has as far as their ability in a population that is very hard to get contact information with, and learning that maybe might be productive for this conversation in their capitated contracts, and how that attribution occurs. Because certainly patients that I know are much more challenging to difficult because of their socioeconomic status. I'd be curious, I don't know if there is any insight from OHA on that topic.
We have been in communication with our OHA partners that, work on the Primary Care Payment Reform Collaborative and the Cost Growth Target. I don't know if Tasha wanted to respond to that question.
I was just going to say, we did look at some of the models, and some of that comes from the CCOs, and the CCOs are the commercial market insurers are required to explain how they do attribution, and there are a couple of options given, but ultimately it's up to the insurer to do that attribution. Thank you.
We're getting close to a time period where I just want to make sure I offer the opportunity for comment to interested parties and the public. So let's go ahead and let's start that now, and I'll come back to you, Deborah, if that's okay. And maybe we'll kick that off with Tom Holt, who's got his hand up, if you would like to make any comments.
Hi, Lisa. Thank you. Good discussion today. I'm here on behalf of the Oregon Association of Health Underwriters. Those are the folks who work directly with purchasers of health insurance, health benefits, and get the brunt of when things go haywire through HR departments. Around this assignment of PCP, just two things. One, I went back and looked at the hearing records on 1529 and the predecessor bill, House Bill 4083, around the primary care portion of what became a complicated omnibus bill. Bottom line, there was no in-depth discussion in open committee on this point about PCP assignment. There are a couple of brushing mentions in some written testimony, but no committee member engaged and asked questions about it, is what the hearing logs show in 2 hearings and 2 work sessions. The work sessions were extremely brief. So I think our view is we concur with all the cautions that have been raised around this, and would suggest, given the paucity of record around this provision, that the win for the division and for the whole industry will be to do what can be done well, and focus on the people who have a record of encounters with a PCP or some other provider who is in effect their PCP based on data. But be careful. You know, the suggestion made by Aaron about a may rather than a will to contact makes a lot of sense. You know, just for example, I have a primary care provider I've been with for many years. That provider is of record with my health plan, but I use on-demand clinics now and then. And so I might have in the course of a year more claims with the on-demand than I do with my primary care provider. You don't want data driving reassignment of me to an on-demand clinic versus the primary care provider who really is quarterbacking my multiple providers. So that's all I have. I think everybody else has made the same points that Oahu views this from. But we do think there is room for you to interpret this.
Thank you, Tom, for your comments. Okay, I think we're going to go back to Deborah. Oh, I should ask, is there any other interested parties or the public that would like to make a comment that aren't RAC members or their subject matter experts or the DFR? Okay, not hearing anything. Let's go back to the RAC members, and Deborah, if you want to make your comments now, you may.
Yes, thanks. Just two quick comments. I think that pursuing and making sure that we're in compliance with HIPAA is really important. And I think that as DCBS looks at that and understands, you know, what language would be appropriate, to really look and understand what OHA does do with assignment of the OHP members, because they do take that step where they assign without a relationship. And so whatever that whatever allows them to do that, I would anticipate would be the same in the commercial population. And so I don't know how they've, you know, addressed those same concerns. And so that just might be an opportunity to review as you write those rules. And then secondly, on the reassignment or the correction process, I believe it's in the rules with the correction process, but to allow flexibility in that, whether it comes from just, and it doesn't have to be prescriptive in rules, but with the intent that it could be, you know, through the patient choice and easy ways for them to make those corrections, or call, you know, whether it's online calling or the health plan outreach or the PCP outreach, because oftentimes if they're coming to a PCP, the patient doesn't want to take that time to make that phone call, but if there's some attestation to be able to allow that communication through the PCP that they are seeing, that would be helpful. So just allowing the flexibility so that there could be multiple ways for that correction process, because I do think that's important. We want to get it right. We want the patient assignment to be what the patient desires, and there's many ways to do that.
Thank you. So that's in with respect to the draft rule sub 5, that last piece, and we just put that in there, that is something that will be worked in collaboration between the, you know, with insurers, setting up a method to do that collaboration with providers. So if anyone has anything to offer in that, on that number 5, please do follow it up in comments. And we have a little bit of like 10 more minutes here, so I do want to offer more time for discussion. And I see Melanie Anderson's hand is up. Please go ahead.
Hi, Lisa. Melanie Anderson, United. I have a follow-up of a question I actually sent you kind of in the interim about the applicability of this to members residing outside of Oregon, given the fact that the definition of PCP is, you know, licensed in the state of Oregon. So just want to, I mean, my assumption is this doesn't apply to members outside of Oregon, but I just want to validate that.
Thank you for the reminder about that question. That should have been on my to-do list to talk to the group about.
Can I just ask a really quick follow-up question? Just to clarify that, Melanie, are these members with Oregon CITES policies and they're just certificate holders residing in another state, or are these also dependents residing in another state?
I hadn't gotten to that level of granularity. I was just thinking about, you know, an employer group, say in Oregon, that has employees in Connecticut or something, how's that going to work?
No problem. We'll have to.
But it could
circle
be
on
both, I guess.
Yeah, that's what I'm getting at, is the certificate situation might be different than a dependent residing out of state. So yeah, we'll talk internally. I just wanted that clarification. Thank you.
Can I follow up on that? This is Jen Baker, just really quick, because we too have a lot of, out of state members at Cigna. So, but like the way I read the bill is that it would apply to fully insured plans in Oregon, regardless of whether they live in Oregon. Is that an accurate statement?
Well, it goes back to a licensed provider in the state. So if someone lives in another state, why would they be aligned up with an Oregon provider? So I'm just kind of processing through that logically.
Right.
That's yeah.
And
Okay,
I think that's where I'm going
that
to,
makes sense.
Jen.
Yeah,
So,
right.
Yeah.
But it does not apply to self-funded. Let's just be clear, right? That's the easy one.
This is fully insured. Fully insured.
Yeah, it would only be fully insured. Yeah. Sorry, I saw something come through chat too. So I was
individual and group. Yeah.
Great.
Okay. Any other questions or comments for the good of the order?
Just really quickly, I see Amy's question in there, and that's another really good example, because the member could come back over state lines to see a provider, even though they were a certificate holder in Vancouver, Washington. I did that for a while. So yeah.
Right. If I could just chime in kind of a little bit on that one. So, but yeah, we have people who cross the river all the time, both ways. So they could live and have a situs to Oregon benefit plan, but they don't live here. So would this PCP requirement be required? Because they're going to probably want, or they could want a PCP in Vancouver. Do they have to? Does that requirement kind of carry over to them, since it's kind of it's a continuous market of Oregon, but at the same time, it's Washington, not Oregon. So something we can validate, that would be great.
And I think that comes down to choice, prioritizing the enrollee's choice of provider. So that would kind of be the lead in the hierarchy.
Would you guys be putting this in the rule then, like the clarification?
No, we don't have plans to put it in the rule. It's going to be in some additional guidance, I think, that Tasha's working on.
Yeah, I'll include this in my additional guidance. I don't think that this is necessarily ripe for rule, but I do understand from a compliance perspective why you would want to know that, and why, frankly, we need to understand it as well. So yeah, we will get information out about this though, even if it's not in rule.
So I just want to be clear on what I heard there. So for saying the member that lives in Vancouver but employed by an Oregon employer, if they say, I want my assigned provider to be a Vancouver provider, we're saying that is okay. So we can assign to providers that aren't licensed in the state? Or are we saying we don't have an answer on that yet? I was unclear what the answer was.
I think we still need to talk, but to Lisa's point, if the person lives in Vancouver and the provider is cited in Vancouver and their policy is from Oregon and they just happen to reside over the river, it would they would have that established relationship. And as Lisa noted, our priority would go to that established relationship, but it is a complicating factor that they're across state lines, and the provider may not be licensed in Oregon. Additionally, usually though, Vancouver is a bad example of that, but yes, Marianne, we have to think through this one a little bit more.
Okay, so if I get that question, the answer is we don't have an answer yet, but we will by the time the guidance comes out.
We're working on it.
Okay.
Yeah, we're working.
I just wanted to not give people wrong information. And I'd see Amy followed up on my question of, does that Washington residing member have to have do they have to be assigned? So I guess there's a two-part question.
Yes.
One, do they have to be assigned? Two, can they be assigned to an out-of-state provider?
Yes.
Okay.
Yeah. It may, be look like a story problem or FAQ.
I was going to say this is law
always
school.
different
the LSAT
situations, but that would be helpful to say if this, then that, if this, then that. So
Hey, Tasha, can I sneak in another question? Is your, because again, we weren't clear on what the scope of this rulemaking was going to expand. We still have that outstanding questions about Section 7 and the patient-centered primary care home and behavioral health home. Are those going to be in the guidance? Okay.
Yeah, so just for folks' reference, Marianne keeps referencing these questions that she sent me, and some of them are subject or kind of are related to conversations that we're having in rulemaking, including around attribution and stuff like that, and touch. And so if the Department of Justice has scared me on nothing else, open meeting law is among the top topics, and I wanted to make sure that we had more conversation here before I release that guidance. So there is stuff, Marianne, forthcoming for you, but I just wanted to wait until we had the conversation.
Okay. Perfect. And I'm happy to share those questions with the group if they're not private questions, if people are open meeting law concerned.
And for the record, before I go to next steps, I did do some follow-up on all of those questions, but one in particular, Marianne, that Cambia had was about the behavioral health homes. That program currently it's in the statutes, but it doesn't exist. It hasn't been funded, so they don't exist. But the other program that I don't have the name off the top of my head, but the other behavioral health program that was OHA oversees, that they provide grants, that does exist. And the patient-centered primary care home does exist. And there's a directory of who's been approved by OHA. So those are a couple things I can just share in this space of the Senate Bill 1529. So let me make sure I'm not missing any hands or comments. Doesn't look like I am. We'll definitely go back to all the comments. Okay, I see Scott's hand is up.
Hey, sorry, Lisa, just one last question. And I was just thinking about this for non-fixed indemnity plans where members can see any provider. I would assume fixed indemnity plans, I believe those, as per how 1529 reads, would be excluded, but indemnity plans that are not fixed, where we have, again, members can see any provider, how do we assign a PCP on 1529, or do we think that they would be excluded? And that doesn't have to be answered today. I was just throwing in a last minute kind of thought or scenario here.
So Scott, can I clarify just a little bit? This might be actually a question for my team. Is this the TOI that is used? There's two types of indemnity. There's fixed and there's the other type of indemnity. So you're really more talking about a health benefit plan that is sort of filed in SURF as an indemnity plan, not an actual fixed indemnity. Okay.
Correct.
If it walks like and quacks like a health benefit plan, even though the SURF title of it is indemnity, it would follow this rule. For those of us who do SURF, there's two different ways to file these. It's getting into the weeds. But Scott, to answer your question, it would apply for a non-fixed indemnity policy, but like the fixed indemnity, $20 if you go to the hospital or whatever into your pocket, it would not apply in that circumstance.
Okay, thank you.
All right. Well, it's 3 o'clock on the dot. I want to say thank you again for your time, your contributions, and your patience with this whole process. And it's really complex, and everybody's input is very helpful with the process. So I would appreciate any written comments you want to share or provide us by August 22nd, Tuesday. That's 2 weeks from now. And I think next steps will involve a third RAC meeting to be announced. It's likely going to be, I can't make any commitments, but I don't think it's going to be before the end of August due to some other priorities. Probably pick this up in September. Not that there might not be other communications in between now and then. So we'll keep the lines of communication open. And thank you for your time today.
Thank you.
Have a good rest of your day.
Thanks, Lisa.
Thanks. And let me stop.